dead space. That's for your respiratory system. You have to carry these things with you forever, you know.
0.3 liters. It's I think it's perfused, but it's not ventilated.
Yeah.
So you guys know Brandon, yeah?
I think that's what
Yes.
Yes? You guys know Brandon. And there's a more muscular gentleman with the cap in the green shirt.
I know Brandon, Mama Lee.
Heidi. Sorry, what's his name?
No.
So you expect that Brandon and that gentleman should have the same dead space? No. Or even some young ladies are even smaller. So what is your dead space then? It's related to your body weight. So what is the dead space in respiratory system? You did that last semester. I mean a year ago. You must have forget these things.
The lungs is perfused, but not ventilated.
That's the definition, but what's the actual volume?
That's one, sir.
Yeah. So we were told in our time it's 1 mil per pound on your body weight. So the 150 normal pounds weight, man. Then it's 1 mil per pound. That would be 150 mils, yeah? So some of you girls don't quite reach 150 pounds yet, yeah? So your dead space will be less, yeah? And that's important for you to remember. Because we have to try to remember, in the brain you'll encounter, sooner than later, a thing called CSF. Yes?
Yeah.
And what is the average volume in a normal man now? It's the same 150 mils. So it's 1 mil per roughly. It's roughly the same as for the dead space. Yeah? 1 mil of CSF per pound of body weight. Yeah? Good. Now the brain. And you can focus on the brain from so far away. Yeah? You all see the brain. Okay, you'll be showing your brain for the first time today, for this term.
Just us.
Yeah.
Observe. You observe me?
Yes, I'm
Is it a short? Watching it. Observe.
Yes, you tell me that.
We have everything.
Okay, so what's the average weight of this brain now?
1.4 kilos.
Sorry? Yeah, so the same numbers are similar, but we're going to increase it by 10, yeah? So instead of 150 grams, it's 1,500 or 1.5 grams, roughly.
Yeah.
And it's a little bit bigger. The brain weight is in the male than in the female, yeah? But in certain aspects of the brain from last semester, especially Mr. Gardner told you that certain aspects of the brain are larger, yeah, in one gender than the other, yeah. Yes. And you can remember one aspect of the hypothalamus from last semester that he said tend to be bigger in we guys. Is that right, Mike?
Correct.
You can remember so far back last semester, because you're gonna have to remember these things, you know. Remember, this hypothalamus was divided into zones, yes? And I'm helping you along. In the first area, right, the preoptic nucleus, also known as the sexual dimorphic nucleus. Remember, you must forget these things, you know. We're going to hit you again with them, comment the term. And it's larger, it's said, in the male than in the female, yes?
Straighten. No. He's trying to straighten the table.
Yeah. Okay, so remember that.
That.
And he mentioned as well, when you look at the temporal lobe, you're seeing the frontal lobes, yeah? And this one here now is a temporal lobe. Eh? There's an aspect on the superior temporal gyrus, this gyrus of the temporal lobe, there's an area there which tends to be larger in female, isn't that right?
Mm-hmm.
He told you last semester. No?
What was the question?
He didn't. All right.
What was the question?
We're looking at differences in the brains. Eh?
Okay.
We showed you where the sexual dimorphic nucleus in the male was larger than in the female. Yes?
Yes.
And in the females, on the superior temporal gyrus here, there's an area where hearing, right, is perceived. You understand? And that gyrus, we'll show you next week or so, that gyrus has some little transverse convolutions called Heschel's, right? Heschel's. He told you, Mr. Gardner told you everything already. And further beside it, but more posteriorly, there's a flattened area. And that flattened area is called the, you remember Mr. Gardner telling you guys? He tells you everything you know,
No, man.
but we forget. It's called the planum temporale. And it tends to be bigger in the female there, isn't that right?
Mm-hmm. To a degree.
Yeah, it tends to be larger in the female. Anyway, so there are differences in the
Sexually dimorphic.
the size of the brain, larger in males and females, but different regions of the brain will show sexual differences. We mentioned the sexual dimorphic nucleus, the planum temporale. And they say that you girls, the frontal lobes, that portion of the brain, want to be bigger in you girls than we guys, you know. And that's the important part of the brain that tends to make executive decisions, you know. So the girls, that's why you girls make better decisions than us, you know. Anyway, so just recapping yesterday, now we have this skull, eh? It's hardened because of its fixation in formalin. But the consistency of the real brain, you'd say is about, what sort of consistency, Mike?
Like jello.
Yeah, you know jello? Or like when mommy make a good bread pudding, just freshly baked. It's
Yes.
soft but firm. Yeah? So that's the consistency of the brain. And this is why the creator made this box, the cranium, to protect the brain, eh?
Called cranial vault.
Yeah, the cranial box or what, yeah?
Yes, vault, yeah.
So you also the skull, how tough it is. It's all tough bone, eh? So you can imagine the softer brain inside there now. And the creator knew that we would be banging each other intentionally
As in like,
of our heads in playing different games, you know, particularly rugby and football. Mr. Gardner is a rugby fan. He likes to watch the girls play rugby. Because the girls, when they play in rugby, you know, in rugby, no holds barred, no? So the girls can grab the...
Lift them up.
yeah, they grab the shorts and lift them up.
That's one way, but they can grab the shorts and pull down the shorts the other way. So Mr. Gardner's being an anatomist, he loves to look at these views, eh? And that's
Sorry guys, I'm chronically unnecessary.
anyway, so the creator now, he knew that the soft brain will be banging against the hard skull. So he had that engineering problem. Yes. So what did he do? He says he has to put some barrier or buffers in between, yeah? And so he created, with a snap on his finger, the Meninges,
Period.
which is what I'm here to talk to you about.
Right.
And to make briefly what Dr. Francis had told you yesterday, the mesenchyme of the neural crest would give rise to the vault bones and the facial bones. Yes? Whereas beyond the midbrain of the study, the mesenchyme there would give rise to the basal bones which of the skull that he showed there. And he mentioned, highlighted the different
Endochondral versus
yeah,
versus
ossification.
intramembranous.
Membranous versus endochondral ossification. So that's briefly the embryology of it. And Mr. Francis and Gardner highlighted several points on the skull. And one of the terms I introduced to you yesterday was the craniometric points. I see a few dental students about here, and you should be quite aware of the craniometric points, because in some individuals, the face and the mandibular bones, they are not as symmetrical as it should be, and that's why we have to see these orthodontic guys.
Oh.
Yeah. The orthodontists make quite a bit of dollars, by straightening up people's face. Nobody wants to build a skin twisted. So the craniometric points are there. And most of the craniometric points will end in the term ION, like the Therian, Asterian, which you're familiar yesterday with, and a few ending in A, the glabella and the bregma, but the majority end in ions. You won't see the craniometric points in your standard anatomy books, but most of you have internet access, and you can Google. There are about 30 or so craniometric points, which you should be familiar with. Should. I see my young friend here. Last semester, she's holding by her chin, and the pointed point in the chin in the midline is called the. Right, Mr. Gardner mentioned that to you yesterday. And what we call the angle of the mandible is known as the cornea. Remember from last semester? So the dental people will measure all of these measurements between them and see where they need to restrain the growth in one area of the jaw versus another. So you can check up on these. The last one I mentioned was Mr. Gardner had highlighted the foramen magnum, the anterior part. There's a part called the basion in the midline, the most anterior part of the foramen. And posteriorly, he mentioned this area called opistheon. Now, opistheon is a new terminology to you guys. And why I'm highlighting that was that when you do pediatrics, some of you will be exposed in or seen what they call the rubella babies. Rubella babies. And one of the features of them, they like to expose themselves, And as they do that, they arch themselves, which I can't do. Arch themselves backward, head resting on the bed there, on the feet, and the back, like an arch bridging. And that position is called opisthetonus, and that's where the opistheon. Which one came first? I don't know. And we had a professor of pediatrics. He was a very fast man, a Jamaican. We call him Speedy Miller. He was there always with his cameras, taking pictures. And he said, while he was getting ready to shoot, little boy shoot him in his eye. Speed? Yes, speed straight in his eye. Opistheon. Okay. So you remember the opistheon when I tell you these stupidities. Another thing that they highlighted yesterday, anatomically, they do it,
Very prominent.
Yeah, there's prominence, And we know that that's the external occipital protuberance. And all the normal individuals should have it. Where there's a certain group of individuals who are not normal that do not have this, and this is one of the features you look for in them. You haven't been told yet, no? The people that have the trisomy, is what, trisomy 21?
Yeah.
The people with Down syndrome who love music. Yes, they love to dance and sing. When you feel the head, they never have this external occipital protuberance. Okay, so I just said that as a reminder, because you're going to be facing little children when they're growing up, so you won't forget that. Now, the actual point is the external occipital protuberance. And the inion, in fact, is where this higher or superior neutral line, you see it? intersects with the base
Very prominent.
of the external occipital protuberance. Yeah. Now, I'm not too sure if on the skull another important surface marking was highlighted, yeah. But certainly I heard Mr. Gardner highlighted. He said the midpoint between the Nasian and the Indian go up in midpoint halfway up on the vertex, and he said 3 centimeters posteriorly, and that is where you'll find the yeah. There's a sulcus here, no? Are you with me now? You can zoom in more. This is the front, eh? This is the back of the brain, of the cerebellum there. This one is the lateral sulcus, and about this one,
Yeah, that big one.
this one here, yeah. That should be the central sulcus, yeah? And he told you what was the answer again? Because he might say that in the exam, you know. The surface marking for the origin of the central sulcus in the midline. The Rolandic point, you call it, Mike?
Yes.
So we told you where to find the Rolandic point, eh? Halfway between the Nasian and the Indian. 3 centimeters or so posteriorly. But then he says to see actually surface mark the actual sulcus itself. He mentioned something which is sometimes not easily remembered. A number. Angle. You remember what he said?
23.
So you all heard that, guys? Yes. You guys at the back remember what he said yesterday? You want to shout it loud, everybody? How much degrees? 67 degrees and 23 minutes. You see how specific he is? Can he imagine the multiple choice? He uses things, numbers close by.
Close by.
Yeah, so you have to be exact. No, and I'm sure if I heard this one, the other important one, because I was there, went for the fun, etc. But the important other one was its area. Yeah. And you remember the surface marking because that's probably the most important one for you to remember.
Right.
All right, you know it in inches, but we tend to be following the French and going into centimeters, you know. So this is 4 centimeters posterior to this angle suture here, 4 centimeters that way, and 3.5 centimeters above the zygomatic arch. Or more easily, 2 fingers worth posteriorly to this suture there, and a thumb's breadth above. And why that is important for you is because, you know, we're always gonna get our heads bashed in, etc. And one of the things I talk about is the extradural hematoma. Sometimes the guys, when you get the injury to the head, as in a football, when they head each other, they might get a little temporary loss of consciousness, but they quickly recover, yeah? And are quite lucid, alert. And then they start to deteriorate, yeah? And sometimes when they reach the hospital to you, they are flat out, not responding to anything, next door to death, eh? And sometimes you might have to do it as a casualty officer, because these guys, they're not feeling any pain, you know. So you just cut in the surface marking area and get this is the drill that the surgeons use. Get a special bit, just like the
round bit.
a rounded bit.
That one is a bit stiff though.
I need some oil.
Oily.
So we drill through there,
Drill.
and the blood is evacuated, and the pressure is released, and the guy wakes up. I might be saying too strong Jamaican language, or what the hell you doing in my head? You understand me? But at least he's recovered, yeah? And you can do that as an emergency. Otherwise, we take them to the theater, give them some form of light anesthesia, and do the surgical procedures. Okay. Now we said the brain was how much again? 1,500 grams. That's heavy. So with just the barriers of the Meninges there now, the brain will be squeezing down by gravity on the blood vessels and the nerves that are cranial nerves that are leaving the brain. So that's a problem, don't it? Especially say when we jump and break dance and all of those crazy things. Eh? So to reduce this pressure effect on these blood vessels, the creator realized that these membranes alone would not suffice. Yeah? So he introduced the concept of, as you saw when the brain was inside here, it was floating in the water, the buoyancy. That is the barrier, the CSF. And that's why I mentioned to you the volume of CSF. And you'll have a formal lecture on CSF production and resorption. Yeah? Good. So you understand that. So
it reduces the effective weight.
yeah.
So that's by whose principle? Which physics? Archimedes.
Archimedes.
So the weight is about
1,500 grams.
1,500 grams, right?
And the
When
weight,
it is in the brain and the fluid, what do you think the weight is?
50 grams.
50. That's a lot. You've gone from 1,500 down to 50. So therefore that CSF forms like a water cushion,
Yeah.
right, around it. Right? So very, very important to appreciate that.
Okay. So
The effective weight. Right.
let's get into
Because all the
some
cranial
action.
nerves are coming out from below, so we can.
Yeah.
Let's get into some action now. The meninges. These are the membranes that lie on the outer surface of the brain, but within the skull. And there are three of them. The outermost is the dura mater. This thing. Okay? Pretty tough. Dura mater. It's the hard mother. Okay? The
Crystal,
hard-
you understand that? Why the word the derivation of dura mater? Mater is Latin for mother, maternal. And
Dura.
dura is hard, tough. So that is a hard mother.
So this is what it is. Now this cranial dura mater, it looks like it's just one layer. Huh? But in fact it consists of two layers. From your osteology, in the very, very first semester, the outer surface of the bone had a layer of connective tissue, as it were, in bracket, that the bone is formed from, right? And that is called the periosteum. Similarly, the skull, it has periosteum on the outside and on the inside. The one on the inside we tend to call endosteum.
In fact, a bit of it is left back here. So that brown layer that you see, turn to a battery. No, over on the other side. This brown layer that you see here, that is the periosteal layer. That's the pericranium. Right?
So, this dura mater, which I have shown you, it consists of two layers fused together. One is the endosteum, yes? That's lying in the inside of the skull. And the dura mater proper. So it's two layers fused into one. This dura mater of the skull, the cranial, differs from that in the spinal cord, in that these two layers are in fact separated. Yeah? So the endosteum, that line in the vertebral column, is just this separate and distinct layer, yeah, from the dura proper of the spinal cord. Yeah. Good.
Give this one here, but okay. Oh, we don't want to. Yeah, the trouble is the other one I don't want to.
Now the dura mater,
Yeah, you're gonna skip it.
the dura mater that surrounds the entire box or skull. Yeah? its attachments to the bone itself. In the vault, in the midline, yes, and where the sutures are. You see the sutures here in this one, yeah? Or in this one, you can see
Yeah, that's better.
clearer, yeah? In the midline, and where these sutures are, the dura is rigidly attached, yeah, to them. In between of the vault, that is, it is not as rigidly attached, this dura, and can be easily, when I say easily, relatively, stripped off, yeah? And some of you will want to become neurosurgeons in the future. You make use of this fact, yeah? Because they always, when they have to operate and remove tumors of the brain, sometimes they have to raise bone and skull flaps together, yeah? So they will go through I think when Dr. Francis held this up to you yesterday, oops, you can see the thinness of the bones in the lower part compared to the thickness in the upper. So the neurosurgeon, he will cut through the thicker, tougher part of the bone. And for the lower part, which is, you can see the thinness of the bone, with the light coming through, he can easily fracture those portions, in creating these flaps, yeah? So you understand that? In the midline and where the sutures are, the dura mater is rigidly attached. But in between of the vault, not so much. However, at the base of the skull now, the dura mater is rigidly attached, not very easily stripped. And this dura will be prolonging, will have a prolongation with the nerves that are exiting through all these various foramina. Yeah? So that is the dura. Now, the dura has been created such that there are a number of folds, like fences, some vertical folds, yes? Some transverse folds, like a tent, yeah? And another one, like a covering, yes? As in the pituitary fossa. They're worried about the diaphragm ocelli, yeah? Mm-hmm. And in addition to, there's also a cave created by the dura, yeah? So there are folds and tents and coverings and caves of the dura. Now the first one, and the easiest one to show you, is this midline. Yes, let's get our bearing right. You see this thing here? That's in the midline, Quite tough and strong, yeah? And it has a sickle shape appearance, You know, the Russians, the communist guys, their logo is the sickle. Okay? So this is the superior, this is the falx cerebri. It dips down between the right and the left cerebral hemispheres there, almost separating the brain into two, but not completely. When Mr. Gardner gets into the brain itself, next week, there's a portion of white matter called the corpus callosum, against which the inferior edge, the free edge of the sickle will abut down in this median longitudinal fissure, yeah? So you see that is one, the falx cerebri, yeah? Now, this brain, this specimen here shows you, yeah, the free edge there. And I'm just showing you, I'm trying to show rather another falx cerebri. It's not shown on those mics. This has been
Oh, you have more midline.
Okay. In this specimen here,
PF 20,
yeah, I come in. You can see the lower posterior portion of the cerebrum, yeah? And then in the midline here now, this is the posterior cranial fossa. You can see a little fold coming on from underneath the tentorium cerebellar, which is coming from the sides there. And it's small, much small, the falx cerebelli. So there are two median folds there, the falx cerebri and the falx cerebelli. The larger is the falx cerebri. Now where does it begin? You were told yesterday it begins at this point here. Yeah? You see that guy? The coxcomb, the crista galli, yeah? You get the attachment there. And just anteriorly to the crista galli. I'm not sure if you've seen that little, tiny little hole there. Are you seeing it?
Yes.
Yeah. What is that hole called again? Ecum. And what's the significance? You were told yesterday. Right. An emissary vein that communicates with the sagittal, superior sagittal sinus, yeah? Communicates with the veins of the nasal cavity, yeah? And the significance of that, especially in little children. You know, the children always pick in their nose, don't it?
Mm-hmm.
Yeah, and get infection, etc. You know, dirty hands, etc. So the infection can spread from the nasal cavity into the superior sagittal sinus and creates a problem. Cause thrombosis, infection, meningitis. Not a good story. Yeah? Mortality is really high. So, running in this superior aspect of
Patrick,
this.
what I want to point out to them yesterday when I was going home, I was thinking about it. Remember telling you about these infections that can go through the cribriform plate and get into the brain. Until some of them are lethal. So you may wonder why. What's the problem in terms of drugs? Because normally, you know, other places you can treat with drugs and you'll get it. But the problem with the brain now is that there's what's called a blood-brain barrier. So the kind of drug maybe that could address that cannot cross the what? The blood-brain barrier. Yeah. So the blood-brain barrier is only going to let lipophilic things through. You get what I mean? Yeah.
Okay, so in the attached midline falx cerebri, we have this sinus. At certain aspects in the midline, the dura mater will form what are called dural venous sinuses, yeah? And at the sides, towards the base of the skull, the dural venous sinuses, where the periosteum, endosteum will remain, but the fold will have a side on this side and a fold on the other side. So we have a triangular space in which we have these dural venous sinuses being formed. Yeah? And these dural venous sinuses are classified as posterior, superior, that they are placed posteriorly, and the superior aspect of the vault of the skull. Yes, that's posterior, superior, and then you have the anterior, inferior ones. So you see the posterior, superior, and contrast that with the opposite, anterior, inferior. Okay? So let's deal with the easier ones first. The posterior, superior, the superior sagittal sinus. There it is. Yeah? And it will receive a number of veins. It can receive from the brain, the cerebral cortex itself, yeah? As it lies within there. On the surface of the brain, as you've seen there, you can see a lot of veins, mainly veins. Eh? And from these superficial cerebral veins, basically they have 2 or 3 groups, the superior, middle, and inferior groups of cerebral veins. Eh? And the superior cerebral veins will drain into the superior sagittal sinus. And I think these collectively are called trollard. Okay, if you can.
Trollard. T for top.
T for top and T for trollard.
And L for low.
Hello. Lab.
Labi.
Labby. You got that? No. Anyway,
Ask her if she didn't get it, Patrick.
you see the brain, the cerebral cortex, yes? And you can see mainly the veins there. I'm saying these veins will drain to somewhere. And these veins are organized into three groups, or really basically two, superior and inferior. You might have like middle as well. But basically superior and inferior. And the superior one will drain into the thing nearest to it, which is the superior sagittal sinus. And those that drain into the top ones here are called veins of trollard.
Trollard.
T for top and T for trollard. Yeah? Where the lower ones will drain into the anterior inferior sinuses and are called LABB, labbe.
Labi.
L for labbe and L for lower. So that's nice and easy to remember, no?
Top and
Yeah, man. Now, when you open the sinus, you see? I'm not
peel
sure.
and prevention.
Yeah, oh, nice.
So,
When you open the sinus, the superior sagittal sinus, are you seeing that now? You can see a lot of fibrous.
fuzzy, looks fuzzy inside.
Yes. Almost like Mr. Gardner's beard.
Beard.
Right? You see them? And you heard about the arterial circle of Willis at the base of the skull. Well, you'll see that sooner than later, in a couple of weeks. The same gentleman, Mr. Willis, yeah, described these as the fibrous folds or cords of Willis. Yeah? And when they are inside together, you won't see any actual opening of these the veins that are draining into the superior sagittal sinus. You have to dissect it open and tear it apart, pull it apart. And when we do that, you can see a little hole here now. You can zoom in sweetheart by my thumb. Yeah? You see a bigger hole, it's magnified on your thing. Some little holes there. You see them? There are the veins that are draining in. So the trollard veins are draining in. Any other veins that are draining into them? The superior sagittal sinus they were mentioned yesterday.
Yeah.
Which the other veins? Sorry? You were told about the diplo veins yesterday. And make sure you understand. Understanding is key in life. When you look at this skull here, it's like, you know, Madam Camera Lady. You can see an inner table of bone, yes, and then see an outer table of bone there. And in between, there's a sort of spongy looking area, yeah? You see that? That space between is called the diplo. D-I-P-L-O, right, Mike?
You're correct, deploying.
Diploid. And that is where the marrow is. And that is what helps to provide some of our red cells. And these areas are drained by the diploid veins. Yeah? And Mr. Gardner mentioned yesterday that how many diploid veins you tend to have again? I always fall back into seeing memory, you know, because they say our brain is aging and atrophy. When you reach about my age, I shouldn't really have any brain left, you know. And as you get into your 20s, your brain starts to atrophy. Isn't that right, Mike?
Correct.
So some of you might be nearing into your 20s and you see your brain start to atrophy. So take care of your brain, guys. Study hard. Muscles, exercise them. Little sleep, study hard.
Wild tea. That's a wild tea.
Okay, so the diploid veins are said to be about 4 to 5, no sir? Right, Mr. Gardner mentioned you have an anterior one, frontal. There's usually 2 temporal, one anterior to the coronal suture, and another posterior to the coronal suture, and the other one was the occipital diploid vein. Yeah? And in addition, another set of veins now communicate with this superior sagittal sinus. You remember he told you yesterday?
Mm-hmm.
Remember, we have to remember a lot of things, you know.
Ask this young lady if she remembers there, Patrick. What's your
I'm
name again?
asking
There?
them all.
Damien.
Hmm?
Damien.
Lydia? Ask her.
She doesn't remember. You see, we have to, doesn't make sense with step one, step forward, and remember what you're coming from. You remember?
Right here.
Yes. If you look here, camera, madam, you catch me?
Oh, the current.
Emissary vein.
Yes, there are veins which are called the emissary veins that interconnect these sinuses with the peripheral venous drainage. Yeah? These are the emissary veins. And they are found in a number of places.
And Peter, you can see all those are situated just in relation to the superior sagittal sinus. You see there? Right.
The emissary veins tend to drain into the midline, superior sagittal sinus, or into the transverse sinus, which I will hopefully talk to you a little bit more about, but not into all sinuses. Eh? So you understand that?
Yes.
Good. Now in the free edge,
No, Pierre, I can ask you a question. Come on, by the name of Paul.
this question from yesterday.
So, Paul, if you're doing some reading, what else is going into the superior sagittal sinus? So, Dr. Lodenquai is talking about some superior, superficial, middle cerebral veins, right? Superior cerebral vein, Trollard. They're also known as the superior anastomotic vein of Trollard. He's also mentioning some emissary veins. What else is draining there? Maybe some nasal veins through the foramen cecum. What else is draining into the? Just use the word draining. What else is draining into the superior sagittal sinus of great import? Yeah, what else is draining there?
CSF.
CSF, 300 marks. 300 marks. CSF. A little or a lot? A little or a lot?
A little.
A lot. How much is produced every 24 hours? Half a liter. That's a lot. Half a liter, 500 mils. So the turnover rate every 24 hours is half a liter. It's half of a box of milk. Yeah, that's a lot, right? For that small space in there. And where is the major site of absorption? The superior sagittal sinus. Where's the main site of absorption?
Superior sagittal sinus.
And how many mils every 24 hours?
500.
That's a lot.
You guys at the back heard that?
Right. And how do they get in? How do they get into the superior sagittal sinus? What are the doorways called? They're one-way valves. What are they called?
The vacuum.
So they're
The
arachnoidvilli, also known as what?
vacuum.
Okay.
Okay. So we're highlighting,
The superior, the importance of the
CSF.
superior sagittal sinus.
you'll be given a formal lecture on CSF production and absorption, etc. Because it's so important.
Touch on you about it, but you have to ask Professor Labutin. He'll tell you the correct pronunciation. Ask him. Ask him. Touch on
Okay. So the CSF is going to be formed in the choroid plexus. You'll be given a formal lecture on that.
Yes.
And it circulates in the subarachnoid space, yeah? And ultimately, it is absorbed and,
Pulled into.
yes, pulled into the superior sagittal sinus by a number of finger-like villi. Finger-like and finger-like is villi. Like in the small intestine, remember about villi? Here? These villi are there, and it's a versions of the arachnoid. And they push into the superior sagittal sinus, these finger-like things. Okay? And whether a number of mechanisms how it actually gets there, whether osmosis or other factors play a part is important. You'll be hearing more about that. Now, when you look in the skull cap, calvera, yeah? The superior sagittal sinus is running in the midline, yeah? And when you look along them, apart from seeing some bigger openings of the emissary veins, you see a number of bigger
Depressions.
depressions in the calvera there, yeah? And these are created by accumulation. Yeah, okay. Sorry. And these are created by accumulation of several arachnoid villi. And when they accumulate together, they are called arachnoid granulations, yeah? And when they become calcified, they are given the fancy name, which Ruff will mention better than I can, the Pacchionian bodies. And they cause these indentations in the skull. The little teeny tiny year-old ones, 3-year-olds or so, you won't see them, right? But as they get bigger, and like me and Mike, we have plenty of these. Our brain is skull is just full of holes, eh?
Terrible.
Yeah. You're on the way.
Out.
So you understand that. Okay, so you understand the superior sagittal sinus, yeah? So we know it starts by the crista galli, communicates with an emissary vein, with the nasal vein. It's really an emissary vein, yeah. And the danger of that. Goes back to the posterior, and in the specimen you can see coming down. And the story is that it tends to divert into the right. Let me show you that.
No, go ahead. No, I'm just trying to make a comment.
Oh, that's all. Okay, when it comes towards the confluence of the sinus by the internal occipital protuberance, which is here. Oops. Yeah, you see the confluence here, right? When it comes down in the midline and reaches here, it might bifurcate into right and left portion, yeah? But the classical story is that it usually goes to the right.
The superior.
Right? And becomes, yes, the superior sagittal sinus, and becomes continuous. Yes, I'm just trying to show myself first. With these two transverse running sinuses
No,
here.
they're asking you to repeat what you said before.
Okay, 23 is the confluence of the sinuses, yeah? The other name for it is what again?
The Pacchioni.
No.
No,
The
torcular neurophilia.
Exactly. They can't pronounce that.
Yeah. In the old time days, you know, the French were good at making the wine thing. And why it was so good was that they used to have barefoot, isn't that right, Prof? And step on the grapes in this wine press. And it looked just like a ship's, what do you call it? The thing that guide a ship, the steering wheel of the ship.
The old thing.
What do you call it? No. Anyway, the steering wheel, the rudder, I think it's the rudder. You know? Yeah, man. So that's why the wine tasted so good. Because the DNA of the French feet were involved in the wine, yeah? Because if you watch on your YouTube, etc., there are no, this racial problem is a real problem, you know. They didn't complain about the Frenchman pressing the wine, the grapes with their bare feet, you know, giving up the day. But if you look on present day, they are now attacking the Indians. Some of our favorite chips. Chips is the Chips Ahoy. As kids remember Chips Ahoy. And a lot of the Chips Ahoy is made over in India. And they are showing you they are being made under some unhygienic conditions. Yeah, you seen it? I said you shouldn't be buying it. Anyway, it tastes good. Chips Ahoy. Because it's the day of the dirty hands. Okay, so you understand that? Well, that's what happened to the superior sagittal sinus. It usually goes towards the right. Now, running in the free edge of the concavity is another sinus, the inferior sagittal sinus. Also in the midline, and it runs back. And when it runs backward, as it coming to this point here now, yeah, when it comes to this you're not seeing it. I'm just trying to orientate myself to show you. In the midline, the inferior one will be running, you know, in a sickle shape in the midline of the red line. And when it reaches the tentorium cerebelli,
So Lodenquai, Patrick, runs in the posterior two-thirds.
yeah, yeah, this, all right, this specimen shows it better. It runs in the posterior two-thirds of the free edge of the falx cerebri, the inferior sagittal sinus.
So guys, watch now, you know, that falx cerebri has a free inferior border and has an attached border.
Attached.
So remember that now, that falx cerebri, falx means sickle, okay? And when it goes back, look when it say there on the screen, when it swings back, it has a free inferior border, and along Dr. Lodenquai is telling you the posterior two-thirds is the what? The inferior sagittal sinus. Then it has an attached border. And that's where you can see now it's attached to the what? The tentorium cerebelli.
See, I'm tenting up the tentorium
Right,
cerebelli.
tentorium cerebelli. And where it gains that attachment is another sinus in between there called the straight sinus. Oh, sorry, I repeated me?
Yeah. So this inferior sagittal sinus, when it reaches the tentorium cerebelli, it receives an important vein, which you all know about from last semester. Great cerebral vena vein. What was it related to again?
This splenium of the conus.
Yes, but something more important than the splenium. The pineal, remember last semester, the pineal gland? The great cerebral vein emerges there. And the great cerebral vein joins up with the inferior sagittal vein to form the straight sinus. And the straight sinus will run backwards, yes? And it is said that it tends to run towards the left transverse sinus. Okay? Said to run towards the left. Yeah. It's draining towards the confluence.
Yeah, you can pull out that before. It's just showing you where it is. You can pull it out.
Yeah, all right.
So look at brain juice when I go to
Okay, so it ranges into the
Put that off.
it's ranging into the left transverse sinus, yeah? And you can see where it's got to be small. The left transverse sinus has got to be smaller than the right because the flow of blood through it is smaller.
That's the straight sinus, draining into the confluence sinus.
All right, so you understand that? So reach the transverse sinus, and for completion of the posterior. Yeah. In the specimen, you can see the transverse sinus is there quite nicely, yeah? Yeah?
Yeah, give it a
No, the transverse sinus is now,
Both sides. In fact,
yes, will continue into the so-called sigmoid sinuses. On the specimen, in this skull here, with me, the internal occipital torcular there, the transverse sinus going there, and at this point, near the petrous portion of the temporal bone, there's an S shape. There's an S shape, sulcus there, where the sigmoid sinus is formed, you see? And the sigmoid sinus will pass through the jugular foramen. And which part of the jugular foramen it emerges? The most posterior part of it, yeah? And becomes the origin of the internal jugular vein, so-called the superior bulb of the jugular vein. Now, running with it, coming into the skull is what? No, man, with the sigmoid sinus. Because we mentioned at the anterior part of the jugular foramen, a sinus is leaving the skull, and that is the.
That's what you said, yeah?
Yeah.
Huh?
That's what you said.
Isn't it the sigmoid?
Yes,
No,
but,
inferior.
yes, but that wasn't the question I had asked.
Okay.
Oh.
And coming into the skull, which is at the anterior part of this foramen, jugular foramen, the inferior protrusion, is another artery coming in. So you see, vein leaving at the front with an artery coming in, vein leaving at the back with an artery coming in. Yeah?
Yeah.
So what are these two arteries now? Right, one is the meningeal branch of the occipital artery posteriorly. Right. Okay, Melly says on the ball, always on the ball.
Yes.
Except yesterday.
Wrong study. Wrong study.
You understand? With the lesser petrosal sinus leaving through the anterior part of the jugular foramen, and arteries coming in with it, yeah? And that is the meningeal branch of the ascending pharyngeal. At the back part of the jugular foramen, the sigmoid sinus is leaving, and an artery, also a meningeal branch of the occipital artery is coming in. Yeah? Sorry? What's that?
At the posterior end.
Yes. So you see, at the anterior vein and artery, at the posterior vein and artery, yeah? And in the middle intermediate portion in between, those are where you have the 9th, 10th, and the 11th nerves emerging, yeah? Got that? So those are the more important, well, almost all of them, but this may or may not be present, yeah? This part of the temporal bone, the hardest part of the bone, is called the petrous, eh? Remember the petrous? Hard. And this is the flattened part, is called the, just a flattened squamous cells are flattened, that's all, on histology. So a squamous is flattened part. Sometimes you'll have a petrous squamous sinus there. It's not always present. And it will drain into near the junction of the transverse sinus, sigmoid sinus junction there. Yeah? Anyway, those are the important posterior, superior sinuses. Okay? Now, the anterior, inferior sinuses, let's get into them. The most important one, you're all experts already. Other sides of the pituitary fossa, or third testicle, what do they call it? Right here. What sinus is located right here? Cavernous sinus. You're all experts from last semester. And it can come again. You don't need to take a picture, you had it last semester. How long is the cavernous sinus? Strange is a little bit long, you might.
Too long, yeah.
Yeah, it's said to be 2 centimeters long.
Yeah.
And how wide is it? half of it, which is 1 centimeter.
Mm-hmm.
And this cavernous sinus begins where?
The superior orbital fissure.
Begins at the superior orbital fissure and then ends where?
Apex of the petrous temple.
Right, at the apex of the petrous temporal bone, yeah? Are the right and left cavernous sinuses interconnected?
Yes.
By what? Right, anterior and posterior intercavernous sinuses. And so we have a circle. And what do you call that circle? Circle of who? Huh? Another famous man's name down in the belly when we did the liver and they wanted to do the Pringle procedure. You push your finger into the foramen Winslow. All right, so I must forget these things. You know. We bring these things up for you to remember all these other things. Okay? You got me? So they are interconnected, yes? And this cavernous sinus now is covered over by right, a fold of Duran called the diaphragm. And it has a hole in the middle, roughly, no? Through which passes the infundibulum and pterygoid. Yeah. Yeah. And Mr. Gardner had shown you we're on the lateral wall of the cavernous sinus. Remember, the cavernous sinus have a number of trabeculae, which divides into a number of cisterns, and that's why it's called cavernous spongy tissue. On the lateral wall was some cranial nerve, no? Right, 3, 4, 5A and 5B, yeah? And he might have mentioned to you a nerve which is called, a cranial nerve, which is called the fiddle on the roof. You heard about the fiddle on the roof? You heard about fiddle on the roof before? Not in anatomy, you know. Never heard about fiddle on the roof?
No, man, you must.
Because we applied that general information, fiddle on the roof, to a cranial nerve. And it's a cranial nerve. It's related to the roof of this cavernous sinus, which is the fiddle on the roof. When we say these things, you remember what I mean? The stupidity is not to remember, don't you? That's why I'm a stupid man.
I think 3 is the most superior.
Number 4, the fourth cranial nerve, is often referred to as the fiddle on the roof, right? Because it's there. Hopefully,
It's just there.
hopefully, we have the specimen showing the fourth.
Let us see it.
I'm going to have my assistant, you know, get him to do something.
Yeah.
I'm trying to find the fourth nerve.
I went mine.
When we started with Dr. Thomas, we used the word 3D in relation to this fourth cranial
here's the
nerve,
bubble.
which is the trochlear nerve.
See the bug on
You
that,
have any
yeah?
idea what this 3D
Patrick,
is about?
See,
Show
there
them
is
for me
it.
now, Mike.
No, man, you show them. See them? Because you're near the camera, you can't show them. See it running along in relation to the freer. See the
Yeah.
boy right here? See him here?
Yeah. Anyway, I'm going to tell you what the 3D is about. And in fact, God and me move it to 6D.
6D.
Wow. This trochlear nerve, as you'll see from Prof, or I think it's Prof. going to be in grade, it arises, it's the only cranial nerve that arises from the dorsal aspect.
Oh yeah, I saw that somewhere.
You saw that somewhere. So that is 1. 2, near its origin, as it, just before it emerges, the decussate. What's that?
The what?
Decussate. You know what I mean by the decussate?
Yeah,
Crossover. And the third D is the smallest, damnest smallest nerve, cranial nerve, which I'll show you soon, you know? And Dr. Thomas left it at 3D. But we moved on to another D. It has the damn longest intracranial course. Yeah? How much we got? 4?
89 millimeters. Oh.
Okay. He's the ophthalmologist.
Length, 89 millimeters. Longest of the cranial, intracranial.
And it will enter it tends to enter the cavernous sinus and its dorsal from its back aspect. dorsally, yeah? And having passed through the superior oblique fissure, which Mr. Gardner had asked yesterday, remember? It is going to one muscle. You all know the formula from your biology. LR6SO4, 3 year.
Oh, the radio.
Oh, no, of the eye.
The superior oblique, that's external muscle. And it ends that muscle on its dorsal aspect, unlike others. So we end up with what? The 6Ds or 5Ds. Okay, be that as it may. Madam Chairman.
Lodenquai, did you point out that it's decimated and deviant?
I didn't use the other deviant. Tell them what deviant is about.
Deviant in that the extraocular muscles are supplied within the cone. So we have a whole cone of muscles coming out. But this one now supplies it outside of the cone. So the nerve is going dorsal to one of these muscles and supplies it like a plane landing. Whereas the extraocular muscles are supplied from within. This one nerve will supply an LR6SO4 3. So LR6SO4, so the superior oblique is supplied by the deviant nerve, the fourth, supplied on its dorsal aspect. So when you open the orbit, you see it just landing like a plane on the superior oblique, whereas the other nerves are within. Yeah, so it's a muscular cone, and all the other nerves are coming inside. Yeah, so it's decimated. So it's dorsal. It decussates. The first thing is it decussates. Before it emerges, it crosses. Right? And it is on the cranial nerve to emerge on the dorsal aspect. If we say it's decimated, it's long and slender.
Decimated.
Damn long. Right?
Decimated.
How many millimeters? 89.
89, like
It's deviant. Right? Anyway, you go find the rest.
Okay, I'm not sure if you can see what I'm trying to show you on the camera. You see this little, beanie little?
No, you can't see. You have to orientate the specimen. See the boy there? Look at him. He's like a thread. You see
Yeah,
that
just like a
thread?
thread.
You see it clearly, man, right above the red probe.
Resting on the red probe.
So that is which nerve?
Did you get that?
Which nerve is that? The trochlea.
Dominic, did you get that? Oh,
It's
get it.
decimated, very small.
So you see how small it is? And in a lot of the specimens that we get, it's torn when we're removing the specimen. Eh? So it's very, very tiny. Eh? And when you look, it's running on the roof of the cavernous sinus. Eh?
Fiddle on the roof.
Fiddle on the roof.
Wait.
Okay, so you see him?
You get a boyfriend like that, you leave him. Fiddle on the roof.
Okay, so you all see this fourth nerve, right? And you understand that. That's the cavernous sinus, yeah? We mentioned the intercavernous sinus, yes? Now, on this part of the bone here now. What is this part of the bone again, madam? Sheath. What's this part of the bone for? The foramen magnum. Going anteriorly, we have this. Huh? Clivus. Right? It's declining or inclined. Right? And Mr. Gardner said that the Latin origin yesterday of the clivus. Right?
Slow.
Slope. Yes.
No tilt.
And on the clivus, you don't need temperature clivus. And on the clivus, you have a plexus of veins
Yes.
called the basilar plexus.
Patrick, this is a very interesting skull. Let me show you something. Whoa, this is beautiful. Look here. A beautiful foramen of Vesalius. See it right there? There's a foramen of the anterior medial tree and very large. Remember I was trying to show that? That's a foramen of Vesalius.
Okay.
Beautiful day.
All right. Focus on it, please. Focus. You see that oval shape opening with the probe we just removed, yeah?
Right.
Yes, you didn't see?
Right. Give a chance. Give a chance. Give a chance.
See the oval shape opening? And when I remove it, when I remove the probe, it looks more oval, don't it? So the foramen,
Very good.
ovale. And this is where she did perform well yesterday. You know. The
My
Mrs.
mnemonic was made sense. You guys know. It did.
Okay. I mentioned when you think of the foramen ovale, I think of O'Malley.
Like Georgia. Right.
And the male, you all know what the male that passes through. The O doesn't pass through. So what is the O of O'Malley about? It's just below the foramen ovale on its medial aspect, eh?
No, I just get.
Two roots nerve at that street, you know? What are the two nerve roots again? Two little rootlets. Mr. Gardner showed you last term. Yes, man, he showed you. What's attached to the otic ganglion? We can ask you these things again, you know. This is all neuro. Got it, man?
Correct.
There's a picture on there.
No.
Let me see. I'm gonna remember.
Auricular temporal nerve.
Right. Auricular temporal nerve. Carrying parasympathetic fibers to the cartilage gland. Don't forget these things, man. Yeah? So that's otic ganglion. Yeah? And passing up into the skull between the two roots. Mr. Gardner mentioned it then. Last semester, he mentioned it yesterday, but he didn't highlight it, which I'm highlighting to you now. Passing between the two roots is the middle meningeal artery. Right? So that's nice and easy to remember, man. So we have the basilar plexus, yes? Going back a little further now, on the foramen, the margins of the foramen cecum. Here, foramen cecum. Foramen magnum, yeah. The whole slip sometimes, yes. Sometimes we might have a sinus called the...
No, that's doing it.
Yes, leave it like that, right? Which you call the marginal sinuses, yeah? Sometimes on the margin of the foramen, the magnum, they might be called the marginal sinuses. And they usually might pass forward up here along the occipital sinus, into the occipital sinus. It can continue to the confluence as two separate little things, or they can more commonly fuse the two right and left to become one occipital sinus, yeah? Good. Now, we mentioned the cavernous sinus, and draining into the cavernous sinus is a sinus which runs along here. This is the lesser wing of the sphenoid bone. You seen that?
I love how you all knew that.
You see that now? Lesser wing of the sphenoid. The other sinus which runs alongside us. You remember? The sphenoparietal sinus. Because this is the lesser wing of the sphenoid, and this is the parietal bone over here. So parietal, sphenoparietal sinus. And it will drain into the cavernous sinus. And the cavernous sinus now will drain into, what do you think, was one that run along. You see the petrous hard bone here? You see a groove, right? Right. You probably not appreciate it so easily.
You have to believe there's a groove first, and then look for it, and then look for it.
There's a groove, yeah, you can, yeah.
I mean, I was not looking.
This is the superior petrosal sinus. And it drains, yeah? It drains the cavernous sinus, and it empties into the junction of the transverse and sigmoid there. Right? Sorry?
The aster is at that point, he said yesterday, with the superior petrosal, the sigmoid and the transverse sinus.
Oh,
No,
yes.
that's what I'm talking about. We know everybody at family.
You mean he mentioned this point here, sir?
Yes, and he was saying that Barnett asked
Huh?
about it.
The Aster.
And yes, and it
Asterisk.
relates to the
Who
junction
asked?
of the three.
You.
That's the Barnett.
Yes, what he asked?
About the Asteria.
Right.
And you said it's the junction of the three. sinus.
Yeah, go ahead.
Yes.
The transverse becomes
Transverse.
sigmoid
And
and where the
Right.
superior petrosal. For the superior, just always remember that the superior petrosal sinus drains into the junction of the transverse and sigmoid.
Okay.
And junction of transverse and sigmoid is
Is
asterion. So the three things.
Okay.
Okay, just highlighting. If I should draw a circle at this immediate point, yeah, you seen it? If I should draw a circle at this point here, like that, what car sign you see?
Car sign.
Is exactly. So when we tell you things, you know, you must have vision.
Wait. Mitsubishi.
So what's the answer? Is that
What's the answer?
Okay. So you have one going so, one going so, one going so. That's the Mercedes-Benz sign. Understand it? Yeah, man. So I'm here teaching you. I'm here teaching you. You know, I'm here teaching you to aspire to own and drive a Mercedes-Benz when that time comes.
inside? It's gonna be a black AMG convertible version.
So the Asterion is the Mercedes-Benz sign. Understand me? And what we didn't mention last semester because we hadn't mentioned it. When he had stones in the gallbladder, many stones in the gallbladder, in the old days before ultrasound was about, we gave them a dye to take orally, and it's absorbed by the liver, got into the liver, and concentrated in blood and secreted out. And when it gets in and amongst the stone, these are what I call mixed stones. You remember they talked about mixed stones from last semester? They tend to rub against each other and become flattened. The mixed stones are flattened. And when the dye gets in between the stones, like these are two stones, remember fissures? You can see some dye get in, and if you put another stone down here, you can see a Mercedes-Benz sign. Yeah, but some of you are taught that you only see stones, and you end up working and earning stones. But some of us were taught to look for the Mercedes-Benz sign and work hard to drive a Mercedes-Benz, a Mercedes sign.
So
It's
that's
all.
what you drive, sir.
Eh?
That's what you drive.
I'm not telling you what that's So,
I think
this is what you should work hard.
so.
Work hard and aspire towards that, yeah? Okay. You see stone, but look at the other positive. You see a Mercedes-Benz sign telling you. Okay, and running from the apex now, running from the apex of the Petrus part of the Timberland Road, draining the cavernous sinus as well, is the lesser petrosal nerve. And we talked about nerve, lesser petrosal sinus. And we talked about that already, no? Good, so that is the dura and its sinuses, eh? Good. So we're getting into the second part of the meninges now, huh? The dura mater is often sometimes referred to as the pachymeninx.
The what?
Pachy, like a pachydermis that does the animal when you remove the skin, yeah, and they preserve, you know, the animal. Huh? Pachydermis. Okay. Now the pia is intimately connected or related to the brain. It follows all the gyri and the sulci of the brain, the pia. Sorry? Yeah. Where the other one in between is called the arachnoid matter. And anything arachnoid is related to spider. And it tends to follow the contour of the brains, but in certain parts of the body, of the brain that is, there are bulges. And so whereas the pia will follow the bulges of the brain and the depths, the arachnoid does not. Okay? And the arachnoid is best demonstrated by Mr. Gardner. He has all the specimens. When you guys need anything, just show Gardner, you know? Financial and otherwise.
Otherwise, it's crazy.
Huh? You didn't hear that, you know? No, I'm not sure if the camera can show you this as well as it should be. Yes. You see that, guys?
No.
The wooden probe there is lifting up this translucent spider web, arachnoid matter. Yeah? You see that? It's lifting, tenting it up.
Sorry, my phone was in the car. Somebody's coming to see me, so I'm going to be the
Okay, so you see the arachnoid matter. And they didn't read about the fiddler on the roof. So you didn't read about Gulliver and the Lilliputian people. The small people know. Never heard about that story.
No, I don't know read nothing.
If there's any guy that's reading, man, when they're young, when they're going to read it?
Yeah.
When you have the grandchildren? Or when you reach by you don't have grandchildren, that's when you're going to read it to them. Yeah, man, you never heard about the story about the Lilliputian people, which are many people, you know. It's a story not true. The Lilliputian people, they are 6 inches tall.
Oh, me know who you are talking.
And this giant Gulliver became shipwrecked and managed to swim to the Lilian Island. So he was a giant on the island, and the Lilian people were little. You can imagine me being 6 inches tall and see a 6-foot man come to my island. I'd be nervous of him, don't you? And that's what they were scared of him.
They tied him down.
And they tied him down with their little tiny
When he
ropes.
was
You can
asleep.
imagine them. And in fact, they tied him down. And ultimately they became friends. Yeah. And this arachnoid, you know, does similar. It sends.
Sir, I'm lost.
See? What's your thoughts? Lillian?
Give a chance.
I don't know where.
I'm just giving you the analogy
Yeah,
of a
the
story that was written by an Englishman. I don't remember his name. You remember his name? It's an adventure story for children
Yeah.
by Gulliver, was a Norman 6-foot man. He was traveling in a ship and it became shipwrecked and everybody died except him. And he swam to the island of Lilliput, where the Lilliput people lived. But the Lilliput people were just 6 inches tall at normal. You can imagine
Big 6 foot.
a little 6-inch man seeing a big 6-foot man come there. They were scared of him. And while he was sleeping from the shipwreck, exhausted, they tied him down with their tiny little ropes. A whole heap of little tiny ropes in.
All over.
Yeah, all over. Yes. And this is what the arachnoid does. It anchors the brain. It anchors the brain to the pia by several little arachnoid strands or trabeculae, they call them, to anchor the brain in this position. So you see the analogy?
That's why it's called arachnoid. You told them if I
Yes,
spider.
So, you know, we have to be good. You have to be good storytellers, you know, to keep you awake. When you all become parents, you have to go tell your little child or the children. Yes, baby stories and keep them enthused and smiling and have a good night before they go to bed. So you have to learn to talk these stories to the children for them to understand things well. So these are the arachnoid granulations. I mean trabeculae, yeah?
Trabeculae.
And we talk about the arachnoid villi and the granulations already and the fasciole
Yes,
and bone.
we did.
Good. Now, between these layers of meninges now, and hard skull and soft brain, there are a number of spaces.
Oh,
Yes, a number of spaces. And the first space we should mention is the so-called extradural or the epidural space. Yeah? We showed you where the dura was strongly attached to the midline superior. This is the sagittal sinus and the superior. But otherwise it was easily stripped off.
Okay.
And when you look at the Mr. Gardner and Francis showed you yesterday, the foramen spinosum. Oh, I showed you the oval foramen which was there, right?
yeah.
And if you look there, so cameraman, are you with me?
No.
You see a little opening there.
Accessible.
You see? Foramen ovale, and you see another little opening there.
Could you tilt the skull, please? Thank you.
Thanks.
Thank you.
That's the so-called famous foramen of Basilius.
Okay.
Wait, read again. Read again.
Emissary veins.
The accessory emissory.
Uh,
Okay. Some things you'll see on some skulls, some you won't see on others. Anyway, back to here now. We saw the foramen spinosum, yes? And you can see the foramen spinosum. Through its middle meningeal artery coming divided into anterior, frontal and posterior parietal branches, yes? And you can see them groove in the bone, yeah? And over the terrain, when you get a hit, yeah? The guys go to hit each other, hit each other, the ball, and they one bump the other. Some are done intentionally when you watch a football match, is done it. And some are accidents. Yeah? Or for the cricket ball, swing and hit and fast ball bounce and hit you there. It cracked the skull. Paper thin, yeah? Pretty thin. And when that happens, it tears the middle meningeal artery and it bleeds. I said there's a concussion initial force, make you lose the conscious, but you wake up back pretty soon after throw cold water and etc. And you're quite lucid and say, yes, I'm at a cricket match when you ask them where they are, etc., you know? But then they start to deteriorate, yeah? And especially when it's happening on the left-hand side and right-handed people, Mr. Gardner mentioned it yesterday, you'll have what problem? Start to affect them. Like when my mom gets tired, I have trouble speaking. So I don't talk too much. They have difficulty. Aphasia. The broca's area is right there, no? On the line. And then you know you have a subdural hematoma. Right? When you do imaging studies of it, you see, if you have time, for the sexual dura, remember it's arterial bleeding in high pressure, so it strips off the dura readily. That clot between the hard bone and the dura is ovoid shaped, and it looks like a biconvex lens. So that's the appearance on imaging study. Whichever imaging study. You understand that? It's like a biconvex lens. Okay. Now between the dura proper and the arachnoid is another space. The subdural space. Yeah? And the space also has little tubes of fluid as well, you know? It's just a tiny. But the important thing is that you have veins that traverse there. They call them collectively bridging veins. Now as kids, you remember when they go bushman?
No.
They go hunt, look for mangoes and all that things. You guys never seem to have an exciting childhood. You know? Huh? Well, other things you go look for guava and other things, man.
In the summer.
They're in,
Ask them
they're
if
in
they
our
ever go to the
yard.
bush in the summer. Ask
In
them
the
about
yard.
Anyway, sometimes you pick up a pot. You know, what that tree is called again that has the peas in them?
a piece.
No man, you know, it's long. It's all. After anyway, those of you who've been in the country will know these trees. So when it is freshly dropped off the tree and it's green, and you shake it, no problem, you don't hear no noise. Eh? Give it time to dry. And you shake it. It's happening to us. How's that part? When we get older, I said when you reach 20 and moving up, your brain starts to atrophy. You guys know that your brain starts to atrophy because you can't remember anything, don't you? And that is truth. You understand me? Your brain starts to atrophy. Your blood vessels lose their elasticity and become brittle. So when you shake the pea pod, when it dry, it breaks that pod. You never see a peanut pod yet? It has that little stem that attaches the pod and the pea together. When it's green, shake it down, it don't break. But when it's dry, you shake it, it breaks, and then you hear it crackle. And this happens to older people. It happened to my brother. I was in the bath, and the bath is a dangerous place to be in. This guy Armstrong walked in space. You heard about Armstrong, the American astronaut that walked in space, or first one that walked in space. And he did that brilliantly and no problem. And in his home, in his bathtub, he slipped in his bathtub and developed this problem. He tear that bridging vein, and that vein will bleed, eh? But the rate of bleeding is slow. Slow, not as dramatic as the artery. And he gets what is called a subdural hematoma. It just gets bigger and bigger. And at times, with time rather, this hematoma starts to break, organize and break down. And theoretically say it becomes osmotically active. So it starts to imbibe water, fluid into it. And so this thing gets bigger and bigger. Eh?
If you damage the
You understand?
protein,
So that's a subdural hematoma. And they get headaches. They don't remember, sometimes the guys don't remember what happened here. But if you can trace back. So they get the headaches, you understand me? And then they start to do what Mr. Gardner likes to do. He said, Mr. Gardner likes to hug up you girls, don't it? Most time. But if you see him start to try after the guys, you know something
No,
wrong.
man.
You know something going wrong. Yes?
Wrong, very wrong.
Very wrong.
Very wrong.
what are we looking at?
So when that's to tell you that there is something wrong with his head, you know, and you're going to send the patient for an imaging study. Not very many lateral heads inside. And the imaging study will show a space occupying lesion. Whereas the extradural was convex. Yes? The subdural now will follow the contour of the brain. Yeah? You saw the brain. And so it will have a concavity appearance, concave.
Let me
Yeah?
write it, please.
You can understand that? So that's a subdural hematoma, a chronic subdural hematoma. And all you have to do is use the drill and make a bore road and wash out the blood clots, clean it out, and the guy will recover. Okay? So it's common in older people as they slip. Just a little shake and it happens. Eh? The next one is the blood vessels run in the subarachnoid layer, you know, arteries and veins and things. And you can get a subarachnoid hemorrhage. Eh?
On the surface of the brain.
On the surface of the brain. That is what most commonly happens when you hear people get
A
strokes.
bleed.
And bleed. Okay?
And in that little lumbar puncture, just look for blood now
Yeah.
in the CSF.
Or breakdown products in blood,
Blood.
xanthochromic, rather than a clear CSF.
Right.
But I was saying, yeah, the PF following the contours of the brain, the bulges and the grooves, but the arachnoid does not. So in certain parts of the brain now, you have, in bracket, bigger spaces where the CSF can accumulate, yeah? And these are called the CSF cisterns. arachnoid
The subarachnoid cisterns.
Okay? Yeah? And the largest one is right at this angle. Oops, we'll put it this way. When you look at the back of the brain, the largest one.
You see it there, right?
This is the cerebellum, yeah? And this is the medulla.
Yeah.
And you can see,
Beautiful, see it there? Very nice.
see I'm lifting the
Cistern
arachnoid here.
magnum.
And you can see the space there.
Magnum, cistern, magnum.
So this is called the cerebellar medullary cistern, or it's called the cisterna magna. Yeah, it's the biggest one.
And flowing into it, there's an aperture in the fourth ventricle known the foramen of Magendie, right? Magendie, that will now drain, the CSF drains directly into the cisterna magnum. Yeah.
So you understand that?
You have a questions.
If what?
Is it subarachnoid
Magendie.
What causes shaken baby syndrome?
The shaking baby. I didn't mention. Did I mention shaking baby?
No, she's just asking.
And you'd have to ask a pediatrician. You know anything about shaking baby syndrome, right? Prof, you know of any shaking baby syndrome?
Ask Crystal.
Shaking baby syndrome.
So when the parents shake the kids and kill them.
When you read pediatrics, you ask the neurologist, right? Anyway, Mr. Gardner's professor that taught him all he knew was an Asiatic man, Professor Thay.
Mm-hmm.
He's what? Indonesian or Malaysian?
Indonesian.
Indonesian. And he said in his time, when you didn't know anything, you know, fits, epilepsy,
Epileptic.
they didn't know anything. They were trying fishing. That's what the physicians do.
Right.
Surgeons are spear fishing, you know, spear fishing. Whereas physicians do net fishing. They throw out only by investigations and hope for something to come back positive and that guide it. Whereas the surgeon knows that that is the problem and he goes straight to the problem. That's the difference between a surgeon and a physician. Understand me? Surgeons are spear fishers, whereas physicians are net fishers. Okay. So in the old time days, when they didn't know anything about epilepsy, they'd puncture this cistern magnet thing. When the guy came in with having had a fit, they just sedate him, keep him still, and Prof would go through the back of the occipital region here, so, and pierce the atlantoaxial membrane to get into the cisterna magna thing, you know, and aspirate some CSF, hoping to find an answer for epilepsy. But they never ever did. But that is dangerous, you know, because the medulla with all its vital centers, as you learn about, is right beside it. And if you go too high or too low, it can cause demise of the patient. And in fact, we don't want to do any puncture there anymore again, as far as I know, you know? Good. JP has gone, no, it hasn't gone yet. But JP and I are very small men, and we tend to have a big belly. Don't it?
Yeah.
I hope you don't hear me. And Mr. Gardner likes to call this portion of the brain the big belly.
Or the
man.
beer belly.
Or beer belly. He's a beer man. You know? Beer, the pons. Right? And where the thing there, the arachnoid passes over, there's another cistern there called the pontine cistern, or Hilton's waterbed. You heard about Paris Hilton?
Yeah.
A nice lady, no?
I think Paris.
Huh? Paris
I know
Hilton.
her.
Don't know movie, bro.
The Hilton, all of the Hilton people, man, they have the money.
Mm-hmm.
So that's the
Is
thing
it your
here.
sister married to the
Huh? So we're going there in the midline. Cisterna magna, cerebella, medulla, cistern, then we go up through the pontine cistern, or Hilton's waterbed. I'm going up further, Mr. Gardner had highlighted to you in the past, inside here, in this region, between the two cerebral peduncles, you have a cistern there called the interpeduncular cistern. And going more forward, Mr. Gardner had showed you when he was doing the hypothalamus this year also. You see this thing here? That's all right, Mike?
Chiasm.
Yeah, the opticasma. And you have a pre-chiasmatic and a post-chiasmatic cistern.
Cistern.
Yeah? I'm going further down on the hemisection of the brain. But by the anterior neuropore, you remember that stuff there? Yeah? He showed you last semester. I will show you soon this semester. There's a thing called the lamina terminalis.
No, go ahead, Patrick, go ahead.
Yeah, the lamina terminalis. At that point, you can get the cistern of the lamina terminalis. Yeah? At the sides of the brain, where you have the lateral sulcus. Yeah? Yeah, remember I showed you the fissure there. You can get a cistern there as well. Cistern of the lateral fossa, they call it.
Yeah, but that. So also on the midbrain, at the back of the midbrain, on the dorsal aspect of the midbrain, you'll find out when we get on there are 4 big elevations. Those are called the corpora quadrigemini. So there is what is called the cisterna corpora quadrigemini, and then above it, very important, around the great cerebral vein is another cistern called the cistern of the venae cerebri magnum. Okay, so just to say that on the dorsal aspect of the midbrain, there's a big, so the CSF coming out through the foramen of Majandi goes up along the vallecula cerebelli and goes over the what? The superior surface of the cerebellum to the dorsal aspect of the midbrain. And then from the dorsal aspect of the midbrain, there's a cistern that winds right around the midbrain, which the probe is in, and that's called the cisterna ambiens. And that's going to take us right into the interpeduncular cistern.
So you also this?
You follow?
I'm pushing the cerebellum. I'm pushing the cerebellum away from the occipital core of the cerebral. And you see the probe there? The wooden probe. It's raising up that fold of the arachnoid. And that is related to where the superior colliculi is. You remember when you did the pineal gland? Remember the pineal gland tumor sometimes gets enlarged and it can compress on the superior colliculi. And the child will have a certain appearance of the eye. What do they call it again?
Sunset.
Right, sunsetting of the eyes. Remember that? Paranoid syndrome. You have to remember all of these things. You know?
This is cisterna ambiens, good indeed.
Yeah, and this is the cisterna ambiens that you're showing me. All right?
Cisterna ambiens.
Yeah, ambiens.
And who travels in that cistern is that nerve which we are talking about, the trochlear nerve. So the trochlear nerve winds around and travels in the cisterna ambiens. We're having fun now, together with posterior cerebral artery, superior cerebellar artery, and the basal vein of Rosenthal. Enjoy.
No, this
So
is
that cistern that goes, so the midbrain has a number of structures going around it. So the trochlear nerve is coming, right, Patrick? Then the opposite way coming around this side now are the posterior cerebral artery. We just throw it out to you. The superior cerebellar artery and a vein, the basal vein of Rosenthal. So, and all of that, listen carefully, is in relation now to the free edge of the tentorium cerebelli. So in post-inflammatory adhesions, in meningitis, etc., all those structures are compromised, the adhesions and all of that. That's a very important thing at the tentorial hiatus. We're having what? Very good.
Okay. The last portion now, I'm going to talk about this tends to come in the exam.
Oh my God.
They said the best things come last month. You know, the wine at the wedding, the best wine was at the last part, don't it? I remember when I was boarding on campus, the best meal I ever had at the campus.
Was Davia there?
No.
I was right there.
You
He
get
just
mad
didn't
when you're
see
boarding
me.
on campus, it's
Yeah,
all right.
yeah, he didn't see me.
No, it was the last day of the campus when everybody had gone away, you know? The last meal
Yes,
on
yes,
campus.
yes.
So that was it. And you know, lobster is a thing that's,
That's wild.
Lobster?
yes,
You can't bring up that word lobster. Oh, JP's gone.
that lobster was served, the last meal for that semester, man. Because everybody had gone, eh?
Does the Meninges do this?
Yes, and that's when I was living on campus. And they serve us lobster. It was the only ever time they serve lobster, the last, very last. Anyway, what I meant, the Meninges now, you have to know about the nerve supply and the blood supply of the Meninges. That's very important. Eh? Let's deal with the one that they tend to ask you first. The nerve supply. They have whole skull, eh? So they'll pin any part of the anterior cranial fossa and ask you what's the nerve supply to the anterior cranial fossa. Eh? Anterior cranial fossa. Yes, the ethmoidal nerves, anterior and posterior, and those are branches of the
Yeah, nasal which
yeah,
comes
nasal
from-
ciliary.
The nasal ciliaries come from ophthalmic.
Yeah.
From V1 ophthalmic.
So they might put the pin into the middle cranial fossa.
Christian.
So middle cranial fossa, what's the nerve supply to the meninges of the middle cranial fossa? Right, the nervous spinous, which is coming from Mr. Gardner, I told you yesterday.
The Monday.
I'm saying middle cranial fossa. I don't need to show you.
Nervous what?
You know the middle cranial fossa, don't you? Anterior cranial fossa, middle cranial fossa. Once you're hearing me. So the middle cranial fossa is by the nervus spinosus. Eh? What happened?
Well,
Yeah.
I did. I tasted a little bit, but you know they were running out, so yeah.
What about the posterior cranial fossa? What about the posterior cranial fossa?
C1, C2, sometimes C3.
Right. The posterior cranial fossa, if you see the term vagus and hypoglossal nerve mentioned, what in truth is happening is that you get recurrent branches from C1 and 2 and C2 and 3 coming up with those nerves to supply the posterior cranial fossa. You understand? In addition, sometimes the middle cranial fossa is supplied sometimes by a recurrent lacrimal branch from the nasal ciliary. Yeah? So don't forget that. So it depends on how the question is asked and what the choices are. Tricky man like Gonzalo, you just ask him middle cranial fossa and just put it in the lacrimal. You don't know Gonzalo? Anyway, that's another point. The arteries. The arteries. For the anterior cranial fossa, the arteries. Just like the nerve, man. The anterior ethmoidal arteries. Yeah? Coming from off the ophthalmic artery. The middle cranial fossa, I mentioned that already. The middle meningeal artery. And the posterior one. We mentioned the two of them already, didn't we? Huh? Yeah. You see, your brain getting just like mine in traffic, man. You remember nothing. We talk about the inferior petrosal sinus and the sigmoid sinus being accompanied by two meningeal arteries. Didn't I?
Yeah.
Anyway, I think it's probably more hypoglycemic than atrophy is happening to you guys. You want to tell them anything else, Mike?
We did posterior cranial fossa.
Eh?
Posterior cranial fossa.
Fossa, the occipital.
So posterior cranial fossa, nerve supply rich.
Rich.
Last 4 cranial nerves are implicated, not implicated, give meningeal branches. Last 4 cranial nerves. What are the last 4 cranial nerves? 9, 10, 11, and 12. All of them give what? Meningeal. Then now the C1. It's said that the C1, of course, as you know, has no dermatome. There's no C1 dermatome. So it's said that the C1 nerve, the sensory branch of C1 goes up into the dura of the posterior cranial fossa. So there are a lot of nerve supplies to the dura of the posterior cranial fossa. And the blood supply, primarily, well, you pointed out meningeal branches of what? An ascending pharyngeal, right? Sorry to point it. My apologies. And also very important, the vertebral artery.
Yes.
So the chief source of blood supply is the vertebral artery. Now, last thing, remember now, we're talking about those spaces. But just to tell you now, just to tell them that the subarachnoid or real space, subdural real space, the epidural is a potential space, right? So we don't want you to go carried away now. It's a potential space, meaning that if any of these vessels here should rupture, blood now can, pressure of that blood now can cause now the dura to now separate off, right? And look at this again. See the meningeal arteries? So show them the computer. I just want them to see it really good. Look how big those vessels are, okay? So those meningeal arteries, remember now, what you're looking at there is a fusion of the endosteal layer with the dura mater proper. Okay, the dura mater proper is going to fuse with it. So the spinal meninges, Dr. Lodenquai will talk a lot about later, very different to the cranial meninges. The two of them separate at the foramen magnum. The two of them will separate at the foramen of magnum, and the dura will continue downward. Okay? Then the endosteal layer in the vertebral canal, in the spinal canal of the vertebral column, is at a distance. See, the wall is a distance from the dura. And that space is now filled in with fat. And that's called the epidural space. And that epidural space contains what, Paul? Very important. When they're doing a lumbar puncture, they're always pulling when they're going. What does the epidural space contain? He says, what does that epidural space in the vertebral column contain? Yeah, what does it contain? He said, we give him questions and he not. I don't know that at all, and I think he's a little distracted by certain people. We're having fun.
Paul was supposed to answer what passed through the foramen magnum yesterday. That was his homework.
Hold on. We soon get to that. So that contains fat, together with something very, very important. The internal vertebral venous plexus. What does it contain? Vertebral venous plexus, which is a part of something super important in the second part of the semester called the valveless venous plexus of Batson, right? Which explains sometimes that breast cancer may spread directly from the breast to the brain, bypassing even the lung, and also explains the spread of cancer from the prostate to the brain through the valveless venous plexus of Batson. So in front of the vertebral column, there's something called the external vertebral venous plexus. And through the bodies of the vertebra, especially the lumbar vertebra and all of those big vertebrae, there are some big veins that just tunnel through. Those are called basivertebral veins. And the basivertebral veins will communicate with the internal vertebral venous plexus. And the internal vertebral venous plexus travels up and is in continuity with the basilar venous plexus, which is in continuity with the cavernous sinus, which is in continuity with everybody else. Right. So remember, outside of that, that is a what? A potential space, right? And then lastly, very important to point out, just understand that the pericranium is continuous with the sutural ligament, which is continuous with the endosteal layer. And remember, the endosteum is fusing with the dural. So when you get a epidural bleed, you're usually confined to the undersurface of a particular bone. Right. And that's why you get this lens shape thing. End of story.
Say it again.